As our wounded warrior.
I'm okay.
Well, so far you're the only one who has decided to join our lecture.
I know some people were considering skipping because they wanted extra break, but I know Jacqueline would have been there, but she has her teeth test.
She's actually in the conference room, so I have a
Probably
feeling
doing her teeth
she'll
test.
be here a little later.
Yeah, she said she scheduled her teeth test. So I don't know if that's maybe where she decided to do it or not. Because we can take it online.
Well, if this is going to be it, and I'm talking to a empty room, essentially, this is going to be really interesting.
I don't know. Jackie was the only one I knew that like wasn't gonna be there because of taking her teeth. But yeah, I wasn't planning on it being like a full-on thing. It was supposed to be just to remove an ingrown toenail. And then he's like, nope. He's like, this whole thing needs to be taken off. So he took off like more than a half of my toenail. I can't even put shoes on.
Well, I had ingrown toenail surgery when I was in high school as well, so I ended up missing a good part. Oh, there's Brooke. Okay, so we got one other person here. Bethany, she had toe surgery. So apparently, some people told Bethany they weren't going to come because they really felt they needed more Easter break. And then Jacqueline is taking her teeth test online, I believe. And your other colleagues, I have no idea where they are. So, well, there's one. So, all right. Well, they're a coming. So,
All right, well, I'm gonna mute because the house is kind of loud, so you don't hear any distracting noises.
okay. Feel free to unmute if you want to ask a question.
Okay.
All right. It's time. So we'll get started. So I podcasted the contraceptives. I did that in two installments, actually. So we're moving on to the antiviral, antibacterials, and then the drugs for cancer. Got three lectures left. Hopefully, we'll get as much of that done as we can. So the first antivirals will be those that are used to treat herpes virus infections. So these particular drugs will inhibit herpes simplex virus 1 and 2 and varicella zoster virus as well. And they are acyclovir, which is an old drug now, famciclovir, and valacyclovir. Valacyclovir, as you can see, is an ether. It is a prodrug of acyclovir. So acyclovir is oral and it's IV. Famciclovir, valacyclovir are both oral. Here's how they work. So the nucleotides are phosphorylated into the nucleosides rather, are phosphorylated into the monophosphate form. Other cellular kinases will phosphorylate them to the triphosphorylated form. And these drugs, because the thymidine kinase is expressed by the virus, the drugs are substrates for the viral thymidine kinase, but they're not a substrate for the cellular thymidine kinase. Those two enzymes are different enough so that they can distinguish between these two drugs. So the viral thymidine kinase phosphorylates it, turns it into the monophosphorylated version of it. It eventually gets converted into acyclovir triphosphate. That will then compete with deoxyguanosine triphosphate for incorporation into viral DNA. And once incorporated, the acyclovir, as you can see, lacks a 3' hydroxyl group. Because it lacks a 3' hydroxyl group, it will cause premature DNA chain termination, halting viral replication. And so the uninfected cells do not make a thymidine kinase that can phosphorylate acyclovir. So these drugs have very, very low toxicity profiles, consequently. So they inhibit viral nucleic acid synthesis because they are substrates for the virally encoded thymidine kinase. And virtually all herpes viruses encode their own thymidine kinase. So what are they good for? They're very good against HSV1 and 2, pretty good against varicella zoster virus. Not very good at all against Epstein-Barr virus, not very good at all against cytomegalovirus, no activity against HIV. On the whole, these drugs are very well tolerated. Very few side effects that are reported. The ones that are reported are pretty rare. Now, acyclovir is not terribly soluble. If you give it intravenously and you're giving it at high doses, which you have to do sometimes, you can get high concentrations in the kidney. They'll precipitate out and they cause acute interstitial nephritis. So, what's the one function you're going to check before you start someone on intravenous acyclovir? Kidney function. Very good. Kidney function. And make sure if you're giving them a dose acyclovir that they're properly hydrated and you're keeping them hydrated. Valacyclovir. What does that do? Well, there are really rare reports of TTP. Frankly, gang, that's all I could find that was linked to the drug. Everything else is such low frequency, it's not even clear valacyclovir causes it. So valacyclovir is very, very well tolerated. So acyclovir has pretty lousy bioavailability, so you have to dose it pretty often. Because it's an older drug, it's really cheap. Valacyclovir, much better bioavailability. Don't have to dose it nearly as often, but it's more expensive. It's still not that expensive. Famciclovir is a prodrug of penciclovir. Now, pencyclovir is only available as a topical agent. So it's quite good for surface level herpes manifestations. So, for example, herpes infections of the nail bed cause a thing called herpes whitlow. Pencyclovir is good for that. But famiciclovir is available as a prodrug. Now let's go to cytomegalovirus. This virus infects a lot of people. In people whose immune systems work fine, its infections are usually asymptomatic. There's a good chance Isabel, good chance you, Brooke, good chance you, Bethany, have all experienced cytomegalovirus, and you were completely unaware of it. However, this virus gets in an immunosuppressed person, it can cause really, really severe infections. It can cause severe eye infections that can cause blindness. The biggest issue is with transplant patients. They get cytomegalovirus, it can be fatal. So there are two drugs to treat cytomegalovirus infections. Gongcyclovir works very similarly to acyclovir, except that it's a substrate for the CMV thymidine kinase, not the HSV thymidine kinase. And then valganciclovir is an oral prodrug of ganciclovir. So ganciclovir causes dose-specific myelosuppression, and you need to adjust the dose according to renal function or its toxicity will get worse. How are you going to assay myelosuppression in the patient? What test do you order? Myelosuppression causes what? Myelo, what does myelo mean? Myeloid lineage of blood cells. So myelosuppression is
It affects like the bone marrow and
that's it.
decreases the like white and red blood cells and
Yep, that's exactly what
production.
it is. Bone marrow suppression. So to ascertain bone marrow suppression, what test do you order? Complete blood count. Complete blood count. Just draw some blood, send it to the lab, tick the box that says complete blood count, and call it good. Now remember, dose dependent. At most prescribed doses, this person is usually fine unless you're combining it with another drug that can suppress the bone marrow as well. So I would do a baseline CBC, then do CBCs after you started the drug just to see how well the drug is tolerated. Drugs for influenza. Oseltamivir, otherwise known as Tamiflu, which is now available as a generic. Zanamivir, that's inhaled. And peramivir, which is intravenous. All three of these drugs are neuraminidase inhibitors. So the surface of the influenza virus has a membrane. Embedded in the membrane are the H and the N. The H is the hemagglutinin, the N is the neuraminidase. The neuraminidase helps the virus bud from the infected cell. The hemagglutinin helps it get inside the cell. Neuraminidase helps it bud from the cell. If you inhibit the neuraminidase, can those infected cells release the virus? No, they can't. So you don't get productive infection. That's how all three of these drugs work. Oseltamivir, zanamivir, peramivir all work the same way. They're effective against influenza A strain and B strains. They work best in the early stages of influenza infection. They're best used if the patient comes to you and they've been symptomatic for no more than 2 to 3 days. There's no evidence that treating someone after that 2 to 3 day limit that the drug will benefit them. Now, some clinicians will prescribe it anyway. Oh, it's kind of a Hail Mary, won't do any harm, but there's just no evidence it's going to help. The drug is also no substitute for vaccination. Oseltamivir will tear up your stomach. The patient will get very nauseous. They may even puke. Headache and fatigue are if you use it for longer than it's normally prescribed. Usually it's only prescribed for a few days. Psychiatric effects have been reported, but they're quite rare. Zanamivir, you inhale it, so it can cause bronchospasms and coughing. Does not cause any sort of GI trouble. Peramivir, the most frequently reported side effects are diarrhea, nausea, and vomiting. Gee, sounds a little like oseltamivir, doesn't it? There are also rarer reports of Stevens-Johnson syndrome with peramivir. Again, extremely rare. Neuropsychiatric effects, things like agitation, delirium, hallucinations, abnormal behavior. These are more often seen in pediatric patients. And since influenza can cause this itself, it's not clear that the drug is actually causing that. Hypersensitivity reactions to the drug are known. The newest kid on the block is baloxavir. Baloxavir. This drug is oral, goes by the trade name Xofluza, effective against influenza A or B, approved by the FDA for uncomplicated flu in people age 12 or older who are otherwise healthy or at high risk of developing flu-related complications. And it inhibits the ability of the flu virus to replicate its RNA. So this has a different mechanism of activity as the neuraminidase inhibitors. This drug is better tolerated than oseltamivir. So you can see the adverse effects, 3%, 2%, 1%. The drug is well tolerated. So this drug might very well end up replacing oseltamivir because it's better tolerated. Are there any questions on the anti-HIV and the anti-influenza and the anti-cytomegalovirus drugs? Let's go then to a much more difficult topic. And these are drugs for HIV. Now, fortunately, a lot of the drugs that I'm going to talk about are just not used anymore. I'm going to mention them because they end up on the NCLEX. So you should at least have heard about them. So some of these I'm going to run by very quickly. I'll spend more time on the drugs that you will probably see as a clinician. So HIV, human immunodeficiency virus. It's an RNA virus, but it possesses a reverse transcriptase. The reverse transcriptase makes a DNA copy of the RNA genome. That RNA genome, after it is converted into DNA, integrates into the human genome. That provirus can then remain dormant for a long period of time. It will then produce viral RNAs and proteins. Those virions will assemble, bud from the host cell, lyse the host cell, go on and infect other cells. The primary cell that it infects are CD4 positive T cells. But the virus can also infect other CD4 positive cells, like monocytes, like basophils, like what have you. So the biggest targets for drugs are number one, the reverse transcriptase, number two, the HIV protease, which is a cysteine protease, and the GP120, which is the glycoprotein that's used in order to fuse with the target, which is a CD4 protein. We went over the life cycle of HIV and micro. Review that. I'm not going to go over it here. And here are the different antiretroviral agents: anti-reverse transcriptase, anti-fusion, anti-integration, and viral encoded proteases. All right, so there are nucleoside and nucleotide reverse transcriptase inhibitors. Notice there are a lot of drugs listed here. I'll give you a little hint. Very few of these are used anymore. So the ones that get used are lamivudine gets used, definitely. Abacavir gets used. Emtricitabine gets used. Tenofovir gets used. All the others are almost never used. And I doubt very strongly you'll see them on the NCLEX. So do you want me to go over those again? Abacavir, lamivudine, emtricitabine, and tenofovir. Those are the four that get used. These other four that were not mentioned are rarely used. They're just too toxic. So the NRTIs are the nucleoside and nucleotide reverse transcriptase inhibitors. These drugs are metabolized inside cells and converted into the active form. These phosphorylated forms, the triphosphorylated forms of these drugs, will compete for the regular nucleotides that are in the cell for DNA polymerization. Remember, they're substrates for the reverse transcriptase. And as the reverse transcriptase elongates the RNA and the DNA, these drugs will cause termination, thereby preventing viral replication. So these are real substrates for the reverse transcriptase, but they cause chain termination. So these drugs can cause terminal neuropathy, some gastrointestinal disruption. NVD is nausea, vomiting, diarrhea. They can cause bone marrow suppression. That tends to be dose dependent. Hypersensitivity is known. Abacavir is the biggest offender. And people with this specific HLA allele are at highest risk. So before you start someone on abacavir, genetically test them to see if they have that allele. that class 1 major histocompatibility allele. If they have it, they shouldn't go on abacavir. They can cause lactic acidosis, other types of liver issues, pancreatitis, nephrotoxicity, tenofovir, at least a certain form of tenofovir. There's 2 different forms of tenofovir. Can be the worst for this. And then these others are the most toxic, and they're virtually never used today. Stavudine, zidovudine, and adenosine, they're rarely used anymore. So these come in various types of drug combinations. Some of these are still used today. And in fact, when you treat someone for HIV, you will always treat with drug combinations. Epicom will not be used typically because it contains zidovudine. Same thing with Trivizir. It has zidovudine. Zidovudine is rarely used anymore. Then we have the non-nucleoside reverse transcriptase inhibitors. These drugs are not substrates. Instead, they bind to the reverse transcriptase at another site, and they allosterically inhibit the reverse transcriptase. Now, if you use these drugs, you must use them with also with one of these, the NRTIs, because if you use these drugs alone, there's a high risk of resistance arising rather early. So there are 5 of these drugs, as you can see. But again, many of these are not used anymore very much. So there's efavirenz, there's etravirin, there's rilpivirine, there's nevirapine, and there's delaverdine. Nevirapine is rarely used today because it's very hard on the liver. Out of these drugs, rilpivirine is probably the most heavily used. Efavirenz is also used for hepatitis B infection. And out of this group is probably, those 2 are the ones that are used the most. They also come in various drug combinations. So here is a triplet that has tenofovir and quercetabine and efavirenz. Here's Complera, rilpivirine, tenofovir, and quercetabine. You can see this is tenofovir, disoproxyl fumarate, or TDF. TDF is one form of tenofovir, the other is TAF. Tenofovir, alomernate, fumarate, and those 2 drugs have different types of toxicities. As said, these bind to an allosteric site on the reverse transcriptase. So these drugs can cause central nervous system effects, and efavirenz tends to be one of the first offenders. And that's a little small. You may not be able to read that very well. Well, both of you have it in front of you, so you can see it. So it can cause some sleep disruptions and vivid dreams. In some people, it can cause depression, psychosis, and what have you. And if you take the drug on an empty stomach 2 to 3 hours before bedtime, you can minimize that. Rashes, all of the drugs of this class can cause rashes, but nevirapine is a worse offender. You can decrease that by taking antihistamines. Hepatotoxicity, again, nevirapine is the one that's the worst offender. The others will do that, but not nearly as much as nevirapine. There can be metabolic issues, lipohypertrophy, fat starting to grow in places where it wasn't before. It can cause pregnancy, lactation issues, and then hypersensitivities. But because nevirapine is the worst offender and it's not used much anymore, then they're not quite so much of an issue. Because these drugs can tend to be combined with other drugs, they can be used at lower doses, so these don't tend to be quite so much of a problem. So these drugs have a lot of drug-drug interactions. Nevirapine in particular is an inducer of drug metabolism. Efavirenz, they show some mixed induction and mixed inhibitory properties. Rilpivirine is the cleanest when it comes to DDIs. That's one reason why it's used so much. So these drugs are used a lot for patients who are treatment naive, those who've not been treated with anti-HIV drugs before, and they tend to be second line, but they are still used today. Protease inhibitors are virtually never used today. Notice that these drugs all end in navir, atazan, navir, dart, navir, ritone, navir, saquin, navir, irdin-navir, tapranavir, nelfinavir, fosemprenavir, blah, blah, blah. These drugs prevent processing of the HIV polyprotein because you cannot get proper maturation of the HIV proteins. You prevent proper HIV replication. And that's what I said here. The HIV protease has been extensively examined through crystal structures and so on and so forth. So many of these drugs essentially are the fruit of a lot of that really impressive crystal structure work. In fact, some of it was done up the street here at Wayne State University. So these drugs have cardiovascular issues and increase the risk of heart attacks and strokes. They cause nausea, vomiting, and diarrhea. You're better off if you take them with food. They can really be hard on the liver. As you can see, tripranavir is the worst, but all of them have liver toxicities. They cause fat accumulation in the abdomen, breasts, and neck. And they are nephrotoxic, albeit that is mitigated by fluid intake to some extent. Now, ritonavir inhibits cytochrome P450s, in particular cytochrome P453A4. By combining ritonavir with another protease inhibitor, it takes the protease inhibitor's concentration in the blood and jacks it way up. This is a pharmacologic strategy called boosting. We're going to see there's another drug, cobicostat, that's used to boost other drugs as well. Okay, gang, that's all I'm going to say about the protease inhibitors because they're really not used much anymore today. They're just too toxic. And I doubt if they get mentioned on the NCLEX that they'll be mentioned in any great detail. Integrase inhibitors, these are the main guns of most of your anti-HIV cocktails, are the integrase inhibitors. After the reverse transcriptase converts the RNA genome into a double-stranded DNA molecule, the double-stranded DNA molecule is escorted to the nucleus, and the integrase inserts it into the genome of the host cell. By inhibiting the integrase, you can inhibit productive infection. Notice these drugs all end in tegravir, tegravir. So integrase, tegravir. So there's raltegravir, dolutegravir, elvitegravir, bictegravir, and cabotegravir. 5 different integrase inhibitors. Virtually all anti-HIV cocktails will have an integrase inhibitor in them because these drugs are very effective and they're very well tolerated. Eltegravir is the drug with the most drug-drug interactions out of these. It should not be given to patients who have significant kidney dysfunction. Bictegravir is typically well tolerated. Therefore, it's part of the first line therapy for HIV, and it's available in a combination treatment called Biktarvy. Biktarvy. Biktarvy, Biktarvy. Biktarvy is combined with tenofovir alafenamide. So you have emtricitabine. So there's one of your NNRIs. And then with that, you'll have tenofovir and you can never spell this, right? Alafena. This is the one that's sometimes called TAF, alafenamide. Alafenamide is not as effective as a diproxyl fumarate, but the alafenamide is easier on the kidneys. Cabotegravir is a long-acting version that's injectable. So that comes in a combination with rilpivirine, and it's in this injectable version that you get every 2 months called Cabenuva. That's quite attractive to people who can't remember to take pills. Cabotegravir. Dolutegravir is very, very potent, has a high barrier to resistance, and it is also available in drugs like Dovato that contain dolutegravir with lamivudine. That's a 2-drug regimen. And then Triumeq, Triumeq. Triumeq has dolutegravir with abacavir and lamivudine. And what have you. Then there are a few other combinations that have these particular drugs as well. So cobicostat is a boosting agent. It's used typically with alitegravir. Alitegravir is only available in combination with cobicostat. These drugs on the average are quite well tolerated. They can increase your creatine kinase concentrations. And since rifampin will induce cytochrome P450s, they'll cause a breakdown of these drugs. And if you combine these drugs with rifampin, you'll get treatment failure. Finally, there are the entry and fusion inhibitors. So the virus has to bind to CD4 and to its co-receptor, the CCR5 chemokine receptor. These fusion and entry inhibitors prevent the virus from entering. There are two fusion inhibitors. Maraviroc is an oral preparation. It's a pill you take twice a day. It inhibits the chemokine CCR5 receptor. Remember, as the patient lives with the virus for a long period of time, the virus transitions from having a GP120 that primarily interacts with CD4 to one that primarily interacts with CCR5. So Maraviroc is designed to prevent viral infection in someone who's had the virus for a while. Enfuvirtide is an injected drug. It's injected twice each day, once in the morning, once again at night. That is also a small molecule that interrupts the binding site, preventing fusion. So enfuvirtide tends to cause a lot of issues at the injection site that you can see. Can also cause numbness in the feet or the legs, some dizziness, some insomnia, some fatigue. Maraviroc can cause a cough, fever, dizziness, headache, nausea. These other things listed, risk of infections, liver and heart problems, those are not nearly as common. So in enfuvirtide, enfuvirtide is an add-on for tough to treat cases. And Maraviroc is only used for those that have strains that use CCR5 as the main receptor, which means the person has had the virus for quite a while. What do you do if you have multi-drug resistant HIV? There are now new drugs for multi-drug resistant HIV. So there's two that are listed here. There's an antibody. So there's abelizumab. That's intravenously administered every 2 weeks. There's also a tablet, fostemsavir, that also targets the GP120. These drugs have been shown in clinical trials to cause viral suppression in people whose treatment is simply failing. Though stem severe tends to cause things like nausea, vomiting, diarrhea, headache, fatigue, and insomnia. There are reports of elevated liver enzymes and QT prolongation. This drug is a cytochrome P453A4 substrate, so keep that in mind. Ibalizumab tends to cause a rash, fatigue, dizziness, and also some GI upset. Less commonly, you can get infusion-related reactions, fevers, chills, drop in blood pressure. So monitor the patients after they've taken the drug. Hypersensitivity reactions are rare, but have been reported. And then the newest treatment for multi-drug resistant HIV is lenacapavir. Lenacapavir generated a lot of excitement in clinical trials because it's extremely effective in multi-drug resistant HIV, and it's very well tolerated. The most prominent side effect are injection site reactions. These usually resolved within 2 weeks. There were other reports with liver enzymes going up, blood glucose levels going up, and what have you. Those events were such low percentage, it's not clear they were linked to the drug. So lenacapavir has generated quite a bit of excitement. Are there any questions about these drugs? All right. And then the last group we're going to talk about are drugs that are used to treat hepatitis C. Now, fortunately, this has gotten really easy. But you know what? Before we do this, it's 7:45. Let's go ahead and take 5. So go ahead and take a break, and then we'll come back and we'll talk about anti-hepatitis C drugs.
I did my interview for my pharmacist today.
How'd it go?
It went pretty good. I did Walmart here because I was picking up meds anyway. So I was like, got a really random weird question for you. And so she was able to answer them. And I gave her heads up on the drug. And then I came back a little bit later so that she
Oh,
could do
good.
some research on it.
Oh, good. Okay. So, what's your drug?
Sitagliptin.
Sitagliptin?
Yeah.
Yeah. Talked about that one last time.
Yes, I realized that. So for our presentation, do we add any more of our own research or just stick with the things that we discussed with the pharmacist?
If there's something you discovered that's really interesting and you want to include it, by all means, include it.
Okay, also, I mean, I can probably look it up, but how many minutes does the video need to be? 3 minutes? Okay. Can it exceed 3 minutes or is that deduction of points?
I'd like it to be within 3 minutes.
Okay.
So, talk fast.
Okay.
All right, we're back in the saddle, gang. So, hepatitis C used to be treated with interferon and ribavirin. If you know anyone who's treated with interferon, you have to have interferon treatments for about 48 weeks. The drug induces terrible fevers. You're terribly tired and you're miserable. Well, now we have direct acting antivirals. You don't have to do interferon anymore, and it's much better. So, this hepatitis C, it's a bloodborne virus. It infects quite a few people, causes liver damage, causes chronic liver disease, can lead to cirrhosis or liver cancer. One group of drugs are protease inhibitors. They prevent the processing of this 3,000 amino acid polyprotein. So these protease inhibitor drugs, they prevent the virus from properly processing that polyprotein, and the protease inhibitors all end in Previr, boceprevir, telaprevir, samiprevir, so on and so forth. And there are the NS5A inhibitors. This protein's involved in viral replication and the assembly of the hepatitis C virion. So if you inhibit that protein, you can significantly reduce hepatitis C replication. Notice that these particular drugs end in asvir, asvir, decletosphere, elbasphere, lipidosphere, ombetosphere, preventasphere, so on and so forth. Then there are drugs that inhibit the RNA replicase of hepatitis C because hepatitis C is an RNA virus. So the RNA-dependent RNA polymerase inhibitors take that replicase and prevent it from working. And there are two of these, sofosbuvir and disabuvir. Sofosbuvir is a nucleoside polymerase inhibitor. Disabuvir is a non-nucleoside polymerase inhibitor. And there are several different genotypes of hepatitis B, and different drug cocktails are specific for different genotypes. But here's the beauty of it. There are some combinations of drugs that hit all these genotypes. So essentially, you have three different cocktails. And if someone has hepatitis V, you're just going to give them one of those three cocktails. You don't have to genotype test anymore. You don't have to learn all those drugs. You just have to learn a few of them. Pretty cool, huh? So there is a combination called Mavorite. Mavorite is effective against all genotypes of hepatitis B, and it contains the protease inhibitor glecaprevir. So if we back up to the protease inhibitors, glecaprevir, that one right there. It contains glecaprevir plus the NS5A inhibitor, this one right here, pibrentasvir. Pibrentasvir. Mavorite. So Mavorite is effective against all the different genotypes. That's one of the first drugs that you will give to a patient is Mavorite. And you can give this drug to any patient who has cirrhosis, or if they have compensated cirrhosis. And if the patient is treatment naive, you give that to them for 8 weeks. So they will take this drug orally once a day, every day for 8 weeks. On the average, Mavorite is pretty well tolerated, but it can cause headache, fatigue, gastrointestinal disturbances, and you can get some increased bilirubin levels. If the person has decompensated cirrhosis, you can't give this particular combination. Now, what do you do if the patient has decompensated liver failure, liver function, liver cirrhosis? Then you can give a drug combination called Epclusa. This combination, once again, is oral. And Epclusa contains the NS5B dependent RNA polymerase inhibitor, sofosbuvir. So you have a replicase inhibitor, sofosbuvir, in combination with this other drug, velpatasvir. And this can be given to patients without liver disease, with cirrhosis, compensated liver disease. If they have decompensated liver disease, then you add ribavirin. Look at the spelling, right? Da, 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 ribavirin. Yep, spelled it right. Ribavirin, ribavirin. And in that case, if the patient has this decompensated liver disease, they get treated for 12 weeks. Now, what if that particular combination doesn't quite work? Well, then you're going to add this protease right here. Meet the proteases. Voxeloprevir, and that drug, these two drugs plus voxeloprevir. So if you add voxeloprevir, that combination of these three drugs is called Vosevi. Vosevi. So yeah, if your hepatitis C is not doing quite so well, then you could add this voxeloprevir. So that combination can be used for a wide variety of outfits. Now, the side effect profile of Epclusa and Vosevi are about the same, and they go like this: headache, fatigue, nausea, diarrhea. Asthenia, that is kind of a pins and needles feeling in your hands, with weakness, and insomnia. Don't take that drug with amiodarone. If you take it with the amiodarone, you'll get serious bradycardia. And it's not recommended that you take either Epclusa or Vosevi with a proton pump inhibitor. That will diminish its absorption. So all these drugs here now have been reduced to these combinations, essentially, that can effectively treat all genotypes. And that is the hepatitis C drugs. Very good. Are there any questions on any of the antivirals that we have examined thus far? All right. Then that leads us to the antibacterials. All right, we talked about a lot of these in micro. So in terms of mechanism of activity, I am going to spend more time talking about side effects and things like that than mechanisms of activity. I'll mention it. All right, so they attack the cell wall, they attack the membrane, they attack DNA synthesis or antimetabolites. There are lots of different things. Some antibiotics kill them, some just stop their growth. If they kill them, they're bactericidal. If they just stop their growth, they're bacteriostatic. And my little silly mnemonic, as you can see, the ones that are bactericidal, so very finely proficient at cell murder, streptogamins, vancomycin, or quinolones, penicillins, glycosides, cephalosporins, carbapenems, and metronidazole. Bacteriostatic, ecstatic, erythromycin, and the other macrolides, clindamycin, sulfamethoxazole, and trimethoprim, tetracycline, and chloramphenicol. The I guess, is a cheat. Yeah, whatever. Some antibiotics we will examine are kind of narrow spectrum. They're specialists for certain types of bacterial cells. Others are more broad spectrum. They can kill lots of different bacteria. We talked about bactericidal versus bacteriostatic. Antibiotics are drugs. They have side effects. The side effects that are most common are listed there. They can be hard on your kidneys, on your GI tract. They can cause central nervous system issues, hypersensitivities, and then problems with potentially superinfection. So the big offenders of nephrotoxicity will be the aminoglycosides. Gastrointestinal disturbance, any antibiotic can cause gastrointestinal disturbance. They can cross the blood-brain barrier in some case and interfere with nervous system function. Penicillins, for example, at high dose, if they cross the blood-brain barrier, they can cause seizures. Hypersensitivity, typically a type 2 hypersensitivity, and then superinfections. All right, the beta-lactams. Beta-lactams are called beta-lactams because they have this chemical ring, beta-lactam ring. These inhibit cell wall synthesis. They inhibit the function of so-called penicillin binding proteins, or PBPs. Those PBPs are involved in taking the cell wall subunits and cross-linking them together. Cross-link them together. By cross-linking them together, they increase the tensile strength by inhibiting that cross-linking and by inhibiting the insertion of those subunits into the growing cell wall. They weaken the cell wall. They cause the cell wall to lyse, to break down, and the cell to lyse. Beta-lactams include penicillin, cephalosporins, carbapenems, monobactams. So the penicillins in particular, or just the beta-lactams in general, they can cause hypersensitivity reactions. At high doses, they can cause seizures. They inhibit transpeptidases. They lack activity against certain types of bacteria that don't have typical cell walls. Chlamydia, Chlamydophila, Mycoplasma, which does not have a cell wall. Rickettsia, methicillin-resistant Staph aureus. Yeah. So the penicillins, we have the natural penicillins, the aminopenicillins, which are meant to be broad spectrum, penicillinase-resistant penicillins, which are anti-staphylococcal. So these are narrower spectrum. There are the extended spectrum penicillins, which also hit Pseudomonas species. and the beta-lactam inhibitors. The beta-lactam inhibitors, sorry, beta-lactamase inhibitors, they inhibit the enzymes that break down beta-lactam antibiotics. So they, when used in combination with beta-lactams, will extend the spectrum. So these are used in combination with penicillins or cephalosporins or something like that. So penicillins in general have short half-lives, so they have to be dosed multiple times. Be careful in patients with poor renal function. Some of them are well absorbed, many are poorly absorbed. They're bactericidal. The natural penicillins include penicillin G, which is still the drug of choice for neurosyphilis. It has a short half-life and poor solubility, so depot shots are given in big muscles like your tuchus. In that case, you'll use the procaine, benzathine combination. Never give that combination intravenously. The procaine is not good for your heart. Penicillin V is the oral form, and there are some streptococcal strains that are still susceptible to penicillins. So they're good for some staph. They're good for many streptococci. They're not very good for gram-negative rods, terrible for anaerobes, terrible for MRSA, and not good at all for enterococci. They have short half-lives. They have to be dosed often. And I'm talking now about the anti-cephaloccoccal penicillin. So these are meant to be resistant to the penicillin degrading enzymes that are made by staphylococci. Now, these drugs can cause phlebitis. What's phlebitis? Remember? Phlebotomy. What's phlebotomy?
Is it infection of the blood or blood-based infection? I don't know.
It's not a blood infection, it's irritation. Flea means veins. Flea means veins. So it's irritation of the veins. So if these drugs are given intravenously, they can irritate the veins. So always make sure you administer these in large veins. So this group of drugs includes dicloxacillin, nafcillin, and oxacillin. Nafcillin, dicloxacillin, and oxacillin. Those are the three that are available in the United States, primarily used for non-MRSA staphylococci. The aminopenicillins include amoxicillin and ampicillin. Amoxicillin and ampicillin. These are good for several different types of gram-negative rods, for streptococci, for some enterococci. They can be used for UTIs, but resistance is getting to be an issue, so susceptibility testing is important. Ampicillin is usually given intravenously in the US. Amoxicillin is very good bioavailability. Then there are the anti-Pseudomonas, or so-called broad-spectrum beta-lactam antibiotics, penicillins. There are three of these. There's piperacillin, there's ticarcillin, or ticarcillin, and carbenicillin. Carbenicillin is only used for urinary tract infections. It does not get to a high enough dose anywhere else in the body. So it's only used for uncomplicated urinary tract infections. Piperacillin is definitely the most heavily used against pseudomonads. And it's a better drug than ticarcillin, so ticarcillin doesn't get used as much. Also used against various enteric gram-negative rods. Not so good against staphylococci, terrible against anaerobes. So penicillin resistance is due to the synthesis of beta-lactamase enzymes. Beta-lactamase enzymes open the beta-lactam ring and render the beta-lactam antibiotic completely useless. The answer to the synthesis of beta-lactam antibiotics is to combine your beta-lactam antibiotic with beta-lactamase inhibitors. And here are some of those drugs and their combinations. So ampicillin with sulbactam. Sulbactam is a beta-lactam inhibitor. That's Unisys. Amoxicillin with clavulanate. That's Augmentin. I'm sure you've heard of Augmentin before. Piperacillin with tazobactam. That's Zosyn. Ticarcillin with clavulanate. That's Timentin. You can see that the spectrum now of these drugs is very, very extended. Still not so good for methicillin-resistant Staph aureus. Not so good for the extended spectrum beta-lactamase producing gram-negative rods. Ampicillin sulbactam is particularly good for strains of Acinetobacter baumannii. That is a scourge of hospitals in burn units and so on and so forth that cause nosocomial infections. It is a very hard organism to treat. Newer ones include ceftazidime and avibactam. This is Avicaz. Good for complicated intra-abdominal infections and complicated UTI infections that include pyelonephritis, and then Vabomere, which is meropenem with vaborbactam, and it's used for complicated urinary tract infections with pyelonephritis. The cephalosporins have a slightly different beta-lactam structure. So the cephalosporins include the first generation, second generation, third generation, and fourth generation cephalosporins. And now there is a fifth generation cephalosporin as well. As you go from first to fifth, the cephalosporins become less active against gram-positive bacteria and more active against gram-negative bacteria. So the first generation cephalosporins are quite active against gram-positive bacteria. The seconds have more activity against gram-negative, less against gram-positives. Third generations have very good activity against gram-negative bacteria and against some gram-positive bacteria. Fourth generations are largely used against gram-negative bacteria. The fifth generation is a specific antibiotic for MRSA. First generation, there's three of them: cefazolin, cephalexin, cefadroxil. Cefazolin is very heavily used. It's available oral and parenteral. The other two are just available orally: cephalexin, cefadroxil. These do not cause phlebitis. Good for surgical prophylaxis. And in fact, cefazolin is used pretty consistently for that. Second generation cephalosporins: cefaclor, cefprozil, cefuroxime. Cefuroxime comes both oral and parenteral forms. Cefaclor is oral only. Cefoprozil is oral only. These drugs also comes as a cefamycin. Cefamycins are specialists against anaerobes. Cefoxitin is an anaerobe specialist. Cefoxitin. Some of the members of the second generation cephalosporins interfere with vitamin K production, and they can prolong bleeding. They can also cause a disulfiram reaction if you co-administer them with ethanol. So what are you going to tell your patient to avoid? Alcoholic beverages. If they're on an anticoagulant, you may need to dose down the anticoagulant, particularly if it's warfarin. These drugs do not cross the blood-brain barrier. Neither do the first generation drugs. So they're good for community-acquired pneumonias. Cefamycins are quite good for abdominal surgery prophylaxis, and so on and so forth. Third generation cephalosporins. These drugs cross the blood-brain barrier and are very effective for meningitis. So of these, the big gun is probably ceftriaxone. The substitute for ceftriaxone would be cefotaxime. Both of these drugs, you'll notice, are parenteral. These two drugs, cefdinir, cefixime, are oral. Cefpodoxime has more activity against anaerobes. And ceftabutin is oral as well. Ceftazidime is a specialist against Pseudomonas aeruginosa and is given parenterally. So those three drugs you can see there, ceftriaxone, cefotaxime, ceftazidime, they cross the blood-brain barrier. Very effective for CNS infections. They're good for streptococcus, good for enteric gram-negative rods, good for gonococcus, and ceftazidime is particularly good for Pseudomonas. They have activity against methicillin-sensitive Staph aureus, except ceftazidime. Terrible against MRSA, not so good against anaerobes, except for cefpodoxime, and not so good against enterococcus. Now, ceftriaxone, because you can give it intramuscularly, is a good, you can give a patient a shot, and it's a one and done. Ceftriaxone is also renally eliminated, good choice for UTIs. Never give ceftriaxone to neonates. It can cause biliary sludging. In neonates, substitute cefotaxime, always. And that is an NCLEX question that often comes up. Fourth generation, cefepime, very broad spectrum. Good for enteric bacteria, good for Pseudomonas, good for streptococcus, good for methicillin-resistant sensitive Staph aureus. Has some activity against some Acinetobacter strains, not all. Not good against enterococcus, not good against anaerobes, and not good against MRSA. This is used for febrile neutropenia. This is used for nosocomial pneumonia. This is used for post-neurosurgical meningitis, nosocomial infections, urinary tract, lower respiratory tract infections. And then the fifth generation one is ceftaroline. Goes under the trade name Teflaro. Teflaro. This specifically inhibits the modified penicillin binding protein found in MRSA. So it's specific for MRSA. So it's good for methicillin sensitive Staph aureus, good for MRSA, good for streptococci, good for enteric gram negative rods, even hits some enterococci species and Acinetobacter. Not good for Pseudomonas aeruginosa, not good for anaerobes, not good for Enterococcus faecium. It is FDA approved for acute bacterial skin and structure infections and for community acquired bacterial pneumonias. Now we get to the carbapenems. These are really broad spectrum, really broad spectrum. So they include imipenem, meropenem, and ertapenem. Doripenem was another drug, but doripenem has been discontinued in the United States. Ertapenem has narrower spectrum, so it's weird amongst the carbapenems, but meropenem and imipenem are the two broad spectrum ones. Imipenem, when it is given, is metabolized to a nephrotoxic metabolite. So you always give imipenem with a drug called silostatin. Silostatin takes the enzyme that metabolizes imipenem in the kidney and inhibits it, thereby preventing the nephrotoxin production that you get with imipenem. So you always give imipenem as an imipenem-silostatin combination. These drugs are very broad spectrum. They have low cross-reactivity with penicillin allergies. They're very good for mixed infections, so you use them a lot for peritonitis and things like that. Good for infections caused by extended spectrum beta-lactamase producing organisms. Intra-abdominal infections, nosocomial infections, very good for that. Monobactabs includes only one drug, aztreonam. Aztreonam is given intravenously, and it is given in an inhaled form, Caistin. Caistin is specifically used for Pseudomonas aeruginosa pneumonias that you get in people with cystic fibrosis. Virtually the same activity as ceftazidime. No activity against gram-positives. Has no cross-reactivity with penicillins. And now we come to the glycopeptides. These are not beta-lactams, but they also attack the cell wall. By looking at the structure of this molecule, you can go back to aztreonam and you can see, oh my word, that looks a right bit different. That looks a right bit more complicated. Well, you'd be correct. So the glycopeptides inhibit cell wall synthesis in a different way. And I'll show you here in just a bit. So there are 4 of these drugs. The granddaddy is vancomycin. The others are telavancin, oritavancin, dalbavancin. Telavancin, oritavancin, dalbavancin. These are exclusively active against gram-positive bacteria and MRSA. They're very good for strains that are vancomycin resistant. So Enterococcus faecium, you can see is resistant to vancomycin. So it binds to the terminal dealanine dimer that's found in the peptidoglycan subunit. Telavancin has the added bonus of disrupting membrane function. Okay, so the glycopeptide side effects. You get an infusion-related reaction called the red man syndrome. particularly with vancomycin. The patient gets warm, flushed, hypotensive, and they turn beet red all over their body. If you pre-treat with antihistamines like Benadryl, you can stop this. Ototoxicity is still reported, but apparently the renal toxicity kicks in at higher doses. Also, there are better preparations that are clear. The old preparations, they were literally called Mississippi mud water with better excipients. These drugs are not as neurotoxic. Having said that, you should still check renal function. And if you're combining this drug with another drug that is renal toxic, you might want to change to a different drug. Telavancin causes foamy urine and disturbs taste. And oral vancomycin, which is really poorly absorbed, is used to treat Clostridium difficile. All right, and those are all the antibiotics that hit the cell wall. Are there any questions on any of those antibiotics? All right, I'm going to stop right here for tonight. We'll start the fluoroquinolones. We'll finish the antibiotics and antifungals on Wednesday. I'll try to start the anti-cancer drugs as best I can. I'll leave those probably for Monday. You're not going to be here the following Monday, Brooke. So I'm going to, well, I'll have to have the final ready by then, which means Sunday. I'm going to spend all day writing finals. So
We started to learn for information on
we stopped the last test at
We stopped the last test at rheumatoid arthritis.
rheumatoid arthritis. So it's the next thing after that, which is
So it'd be hypertension and then so on.
hypertension on through to the end, which is a lot of material, but that's the way it goes. All right. Thank you, all two of you, for, well, three of you, for showing up. Bethany, you're going to be okay Wednesday, or are you still going to be out?
No, I should be fine Wednesday.
You should be fine Wednesday. Okay. All right, then. Have a great evening, everybody. I'll see you back in the saddle Wednesday. All right.
All right. Good night.